Burning the metallic stent or cannulated. A female patient, 65 years old, undergoing 5-fluoro uracil chemotherapy for unresectable cancer pancreas, admitted to our department by obstructive jaundice. Laboratory investigation show elevated total bilirubin, about 16 milligram per deciliter, mainly direct. ERCP for this patient revealed biliary obstruction in the lower portion of the CBD with dilatation of the proximal part. On CT imaging, we show that there is a hypo-enhanced irregular shaped mass موجودة in the head of the pancreas. If we look to the CT, we found that there is an irregular mass present in the head of the pancreas, and there is a marked dilatation of the intrahepatic biliary channel. We are going to do ERCP for this patient. This is the imaging study, and this is after cholangiography, which shows that there is an marked dilatation of the intrahepatic biliary channel. As we see here, also there is an distal obstruction, or there is an distal obstruction in the CBD. After cholangiography, we started to do sphincterotomy. Sphincterotomy usually done in the apex of the papilla at 12 o'clock, step by step, and the complete cutting of the papilla may be safe in sometimes. Step by step, and avoid rapid cutting as it may lead to bleeding. If bleeding occurs at any time, you have to use cautery or balloon tamponade. In some cases, injection of diluted adrenaline may be needed. You try to cut usually at the apex of the papilla. If bleeding occurs at any time, you have to do cauterization. Then we started to withdraw the papilletome and maintain the guide wire in its side and reinsert the metallic stent into the previous cutting area. This is again the cholangiogram after we are inserting the catheter uploaded by the metallic stent. We have to bypass the distal end of the structure and then started to release the stent step by step. The stent started to open in the upper part of the structure, and then we started to do complete release of the stent. We see here that the stent is totally released with excess biliary mud and secretions started to pass through the obstructed distal end of the CBD by the uncovered metallic stent. After 8 months, the patient coming again to our department by obstructive jaundice. And now we are asking what is the solution for these problems. We actually found that this stent is totally impacted in the other edge of the duodenal folds. We take a long time to disimpact this impacted stent, even we are going to cutting by the argon plasma. After all of this, we started to recannulate this obstructed stent. As it appears, is totally obstructed by the tissue and biliary mud. We started to recannulate this obstructed stent by sphincterotomy. As the stent is infiltrated, we found some difficulty even in passing of the guide wire. We try to strengthen the condition by the sphincterotomy itself. We found some difficulty as we see here, but after times, the guide wire success to pass. We will confirm this again by cholangiography. There is a total infiltration of the papilla from all edges. Now we will looking for cholangiography to confirm that we are maintaining the guide wire above the level of the obstructed stent. And if we look here, unfortunately, still not passing the upper end of the obstructed stent. Now we have to change our direction from side to side and try to strengthen by the papillotomy itself. This is actually an obstacle. We found. We try again and change the position. Now the guide wire pass above the level of the obstruction. And now we started to remove the papillotomy and lift the guide wire above the level of the obstructed stent. After doing cholangiography and to confirm this, we showing that something obstructed this stent, maybe in a mud, maybe in a stone, something like this. All of this mentions that the stent is already obstructed. Now we will try to maintain the guide wire above the level of the obstructed stent. The stent now started to appear again to pass through the guide wire into the obstructed metallic stent. We are trying to approach above the level of the obstruction. We will try. Also, the catheter found some difficulty to pass above this level. The stent appeared to be totally obstructed by the malignant tissue. We try to change the position until complete delivery of the stent occur. In this obstructed stent, we confirmed that the biliary drainage started again through this plastic stent by the bilirubin which coming out. So the message here, rule number one, metal stent insertion is a common palliative treatment for distal malignant biliary obstruction. You have to choose the partially covered stent or covered metallic stent for this from the start to avoid complication like this or obstruction, early obstruction of this stent, compared to uncovered self-expanding metallic stent. Partially metallic stent didn't prolong the stent patency in unresectable malignant distal obstruction. Rule number three, stent migration was frequently occur in partially covered stent. However, tumor ingrowth was less frequent في partially covered stent is مقارنة بالuncovered stent. Plastic stenting inside the obstructed stent may be a solution for some cases which coming by totally obstructive jaundice after insertion of the metallic stent. Many thanks and goodbye.